welcome back. Thank you for joining us for this second session in the Nancy and Bill Norton Patient Educational Series event on gastrointestinal symptoms. My name is Cecile Rooker. I'm the President and Executive Director for the International Foundation for Gastrointestinal Disorders, or IFFGD. Thank you so much for joining us again for a new session on middle GI. So yesterday we went over the upper GI symptoms, and we had some great speakers to talk to us about that. And today we'll be talking about middle GI and the symptoms that will affect that middle part of your gastrointestinal symptoms. As I've mentioned before, I'm extremely grateful to be here in beautiful Boston on a wonderful day, working with folks that are all associated with Harvard Medical School in some way. These folks that are speaking with us this week are healthcare providers, such as physicians. We have nurse practitioners, even medical students and fellows that are giving these wonderful presentations. And these are people here at Harvard and Boston that are really focused on working with gastrointestinal patients, people with the GI symptoms, people like you. And we're totally grateful to have them, and especially grateful for these two wonderful gentlemen who helped put this all together for us. We have Kyle Stoller, who actually has been in Boston for his whole medical career. He is now the director of the motility lab, but he started as a medical student and did all of his training here at Harvard. And we're so grateful for your help in putting this program together. And then Dr. Brad Kuo, who has been at Boston for many decades and is unfortunately leaving, but we're thrilled to catch this program in right at the end of your tenure here in Boston. And so we've had a great time putting this program together for you. And I really hope that it's been educational and enlightening so far. But today's speakers are going to be a real treat. So I'm going to leave you guys to watching and learning all about the middle GI symptoms of your GI tract.
Hello, my name is Brian Surjanhata. I'm a gastroenterologist at Massachusetts General Hospital within the Center for Neurointestinal Health, located in Boston, Massachusetts. In this video, I'm going to talk about the symptom of early satiation, and specifically, what is early satiation, what conditions may cause one to have this symptom, how do you talk to your provider about this, and what testing and treatments may your provider think of based on your discussion with them. Just as a matter of disclosures, I previously served as the principal investigator at MGH for the Atmo Biosciences clinical trial. I only received research funding support just for the study itself. The trial is now closed and I have no active financial interest. Before I begin, I want to outline some of the terminology. Satiation versus satiety. These are often used interchangeably, but actually have two distinct meanings. Satiation itself is the feeling of stomach fullness while consuming a meal, leading one to stop eating. Satiety, however, is that fullness in between meals that persists. So the symptom of early satiation is that when the fullness of feeling occurs after just a smaller amount of a meal, stopping you from finishing the full plate. The tricky thing for us gastroenterologists is that early satiation is a very common symptom, and it doesn't necessarily predict the underlying issue. These are the 6 different conditions or factors in early satiation that we often think about when we first meet a patient. And it's important to note that it is within the context of other symptoms and the overall patient profile that a provider may lean towards more of a one diagnosis over the other, guiding the testing and treatment necessary. We will cover or touch upon each of these factors in the next few slides. How should you talk to your medical provider about the symptom of early satiation? First, when I think of this, is that I want to know from my patients, when does symptoms start? Is it happening with every meal, or is it happening intermittently? Within how many bites or what fraction of a meal portion is causing you to feel full? Is it preventing you from finishing a normal-sized meal? And are there any changes in the meal size you're consuming or the frequency of meals throughout the day? Or are you avoiding food in general? I want to know other symptoms like nausea and vomiting. abdominal pain, and even belching and bloating. Additionally, I want to know your background. Do you have a history of diabetes that may influence the way your GI tract is functioning? Has there been any other GI history, whether it's a short-term GI illness or more chronic GI illnesses in the past? And have you had any surgeries along your GI tract? Additionally, I want to know about your medication history. Are there any narcotics for pain? Are there any medications that are considered to have an anticholinergic property? Meaning, do they potentially slow down the gut? Or are you on any GLP-1 agonists such as Ozempic? All these medications can affect gut function, gut motility, and may lead to this sign and symptom of early satiation. So when you talk to your provider about early satiation, of course they're going to be worried. But here are the factors that makes us more worried. Things like age of onset at 50 or above, any unintended weight loss, signs of bleeding, such as black tarry stools, vomiting of blood, or vomiting of coffee ground-like material that suggests a process up in the upper GI tract, persistent vomiting with each meal, difficulty swallowing, and particularly the passage of food down the esophagus itself, or a family history of esophagus or stomach cancer. These, generally speaking, are considered red flags or alarm signs to your medical provider and may prompt certain workups such as upper endoscopy or CAT scan imaging. So based on the history you talk to your patient about or talk to your provider about, what testing could you expect? What treatments can you expect based on the testing results? Well, for one, your provider may suspect H. pylori. H. pylori is a bacteria that colonizes the stomach, which can cause inflammation like gastritis, ulcers, and certain types of cancer like gastric cancer or malt lymphoma. Typically, it can be tested for non-invasively taking breath samples or stool samples, and if found positive, it requires at least 2 antibiotics, acid suppression with proton pump inhibitors, and bismuth to really treat that bacteria and eradicate it. And usually the course is about 10 to 14 days. It's important to carry through with the treatment because the World Health Organization does classify it as a potential carcinogen. And again, based on the symptom profile, your provider may elect to send you for an upper endoscopy. An upper endoscopy is a direct camera visualization of the GI tract under sedation. It will require fasting, typically at midnight, prior to the procedure to make sure that your GI tract is clear and we're able to visualize everything, but also that you're safe for sedation. And an endoscopy is going to be able to evaluate your esophagus, stomach, and part of your small intestine for anything like ulcers, inflammation, strictures or narrowings, cancer, growths such as polyps, and even take samples for H. pylori or evaluation of celiac disease. We can even remove tissues if there was a polyp that we are concerned about that is causing the symptom. And if there's any narrowings, we can even stretch open the narrowings with balloon dilations. And if there was an ulcer found that was concerning for bleeding, we can even intervene on it to reduce the chance of bleeding. So, with an endoscopy, you may be diagnosed with an ulcer. And the top 2 things I think about with ulcers are as reasons to have an ulcer is from NSAIDs, non-steroidal anti-inflammatory drugs such as ibuprofen or naproxen, and H. pylori infection. The treatment for this is to fix the underlying issue. If it's NSAID-induced, minimizing or stopping NSAIDs will help. If it's H. pylori, the H. pylori treatment will help heal the ulcer. And ultimately, you may need to be put on proton pump inhibitors such as omeprazole for 4 to 8 weeks to promote healing of the ulcer itself. And again, if there's any concern for this ulcer to bleed, we can intervene on with some endoscopic techniques. A CAT scan of your abdomen and pelvis is something that your provider may order as well. It's particularly when there's concurrent weight loss with the symptoms of early satiation or the red flag symptoms that I had discussed earlier. Mainly, a CAT scan is useful to be able to evaluate for structures and organs not seen on endoscopy and for evaluation of cancer. Now, ultimately, when there's no suspicion for any organic disease process is leading to the early sign and symptom of early satiation, or when it's already been ruled out at the discretion of your provider, then they may start thinking about this symptom as being derived from the function of the stomach itself. Now, think of the stomach as the primary vessel that receives food and processes the food that we eat so that our small intestine can absorb the nutrients. But this vessel, this stomach, is actually a muscle and it's able to relax and contract. And so when food is ingested, the fundus is the first portion of the stomach that receives food, and it actually relaxes and holds the food and liquids with a nice hug called accommodation, with very little increase in internal pressure. The thought behind issues with accommodation is that if there's an impairment in accommodation, patients can develop that symptom of early satiation. Now, once the fundus receives food, it'll then contract and then push down the food into the body and the antrum of the stomach, during which the stomach will churn the food into smaller particles and empty it into the small intestine. Additionally, the stomach is also innervated by the vagus nerve. The vagus nerve controls the function of the stomach from a contraction and relaxation standpoint, but also serves as the sensors of the stomach to relay any symptoms of nausea, pain, discomfort, and even early satiation. So it serves two roles, governing the function of the GI tract, but also relaying the sensation that you feel after eating. So that brings us to the next potential diagnosis of gastroparesis. So when there's any dysfunction in the contractions or the sensory aspects of the GI tract, we start thinking about gastroparesis as a potential diagnosis for your early satiation. And gastroparesis is paralysis of the stomach. It means that there's delayed emptying and transit of stomach contents into the small intestine in the absence of any mechanical blockage. Other symptoms that you may have include nausea, vomiting, upper abdominal pain, bloating, and appetite loss. The top two reasons for gastroparesis are diabetes, leading to nerve dysfunction, or idiopathic, which frankly means that at current state in medicine, we just don't know where it comes from just yet. Treatments are multimodal. One is lifestyle modification, and by that I mainly mean changing the way you eat. Our stomach is very responsive to what nutrients we take in, how much fat, how many calories, how much fiber we take, actually affects the way our stomach is able to move and empty. And so in gastroparesis, by doing small frequent meals, low fat, lower fiber with each meal, it helps the stomach empty a little bit better and helps stave off the symptoms. Other treatments may be prokinetics, which are a set of medications that help promote the motility of the stomach and empty the stomach. But time and time again, a lot of research studies suggest that it doesn't always reliably improve symptoms. So with that, your provider may also add neuromodulation. Neuromodulation addresses the sensory aspects of GI dysfunction and in gastroparesis. As I alluded to earlier, the nervous system in the gut regulates the function in terms of the contractions, but also relays a lot of the sensation of the GI tract to the sensory parts of our brain. And ultimately, neuromodulation are mental health medications that are used for a very different purpose. It's not to say that your symptoms are psychiatric or psychological, but it's understanding that while our brain uses these neurotransmitters to regulate our mental health, our gut actually uses the same neurotransmitters to regulate sensation in the GI tract. And what we're trying to do with neuromodulation is to fine-tune the chemical signaling, the balance, to help you with the symptom of early satiation, nausea, or pain, or all three together. Gastric emptying scintigraphy is the way to diagnose gastroparesis, and is the standard test currently. What it is basically a test where you eat an egg sandwich meal consisting of egg whites, 2 slices of bread, strawberry jam, and after you consume that meal, a radiologist will take snapshots of your stomach over 4 hours and actually track how well that meal empties from your stomach. and that may or may not diagnose you with gastroparesis. Other testing that your provider may order that are potentially coming on the market in the near future are capsule-based motility testing, one from Atmo Biosciences and another from ANX Robotics, that is able to measure the transit times along your GI tract from the stomach, small intestine, and colon, and discern if there's any dysmotility along the GI tract that may contribute to the sensation of early satiation. Body surface gastric mapping may be considered as well. These are basically an array of electrodes that gets placed on your abdomen. And similar to how an electrocardiogram measures the electrical activity of the heart, this can actually measure some aspects of the electrical activity in your stomach and point your provider towards a suspicion of gastroparesis, needing more testing to confirm, or point towards a sensory disorder like functional dyspepsia. And finally, your provider may order a small bowel follow-through. This is a barium study with x-rays to evaluate the small intestine, to be able to evaluate for mechanical obstruction or from a stricture or a mass, and also assess how fast things are moving through your small intestine and determine whether or not that's contributing to your symptoms. But when there's no discernible organic disorders such as H. pylori or ulcers, when there's no obvious dysmotility like gastroparesis, then your early satiation may be from functional dyspepsia. There are two flavors of functional dyspepsia. One is the epigastric pain syndrome subtype, where you have pain or burning in the pit of your stomach, or the postprandial distress symptom, where you have fullness after eating, or even early satiation. And you can have an overlap of both. This again is also in without the evidence of structural disease, and typically assessed first with an upper endoscopy to ensure that's the situation. Treatments may include, again, making sure that H. pylori is not a factor, PPIs or proton pump inhibitors to reduce the acid burden in your stomach temporarily to help alleviate symptoms. And again, this may be thought of as more of a sensory dysfunction in the stomach, and neuromodulation with tricyclic antidepressants such as amitriptyline may help alleviate the discomfort and symptoms. So in summary, early satiation is that feeling of fullness, partly through a meal, leading one to stop and prevent them from finishing a full plate. This can obviously impact quality of life, but also may be a marker of GI disease. It's important to be able to know how to talk to your doctor or your advanced practice provider about the symptoms you're having, which may lead them down to certain potential diagnoses and guide their testing and treatment. Thank you for listening.
Hi, everyone. My name is Dr. Nir Bar. I'm from the Neurointestinal Health Center from the GI Division in Massachusetts General Hospital. And today we're going to be talking about bloating and distension. These symptoms are very common and bothersome, and they often baffle both patients and providers. So this is a plan of our talk. We're going to define what bloating and distension are, because they're not exactly the same, although they often occur together. We'll look at how common they are, review some common causes. Then we're going to focus on one mechanism I see a lot in clinic, called abdominophrenic dyssynergia. We'll talk a little bit about how we diagnose it, how we treat it. But first, let's make sure that we're all talking and speaking the same language. Bloating is what you feel. It's a sensation of fullness, gas, pressure. Distension is the actual visible increase in our belly size. The distinction is a little bit artificial because they often coexist. And many people, including myself, use them interchangeably. But for this talk, we're going to stick to bloating is the sensation of fullness, and distension is the actual increase in abdominal girth. And patients with distension often describe themselves as looking like a balloon or like they're pregnant, and they often have pictures to illustrate what happens to them. And I think that a lot of my patients face some misunderstanding or distrust from at least the medical community, and and they need to show the changes that they go through. And I think, and I hope that I'll be able to illustrate how I see bloating and distension. There are many reasons for bloating and distension. Some of them are temporary, like being pregnant or bowel obstruction. And those are, of course, things that we're not going to discuss today. We're going to discuss chronic bloating and distension. And bloating and distension can result from many different mechanisms, which makes diagnosis and treatment a little bit challenging. The Rome 4 definition requires symptoms to last for at least 6 months, and for bloating or distension be the predominant symptoms. And when we use those diagnostic criteria and we look at a survey, an international survey that was done by the Rome Foundation, we know that at least 3.5% of the world's population has chronic bloating and distension. And this condition affects twice as many women as men. This may sound like a small fraction but if you think of the entire world, it translates to millions of people. While this is not IBS, there's a significant overlap. Many patients with disordered gut-brain interaction, like IBS, also struggle with bloating or distension. And patient forums are full of posts describing exactly the same symptom burden that I find and hear from my patients. So what's the cause behind bloating and distension? And there's no one single cause. It's multifactorial, and that's what makes it tricky. Different factors can contribute. These include certain foods and food intolerances, changes in gut bacteria, gut nerve sensitivity, or gut motility, how fast or slow our gut moves and moves the food inside of it. Let me give you a simple example. Let's say lactose intolerance. So we know lactose intolerance is extremely common in adults, affecting up to 60 to 70% of the population. But why do some people have severe symptoms and others can just take their coffee with oat milk and feel fine? The difference often lies in the gut sensitivity. Some people's nerves are just more reactive than others. The patients who come to my clinic usually aren't just lactose intolerance. They've already tried cutting dairy and they still suffer from bloating or distension. People who found relief from avoiding dairy probably won't present to my clinic. I won't see them because they're fine. They won't go through the trouble of making an appointment, going into Boston. My patients have something different. In my clinic, I see more challenging cases, people who've already tried adjusting their diets. Some of them may need help with managing constipation. Others can benefit from other dietary interventions like a low FODMAP diet. But the patients I want to talk about today are different. And their problem isn't something they ate. It's something a little bit different. So if we use this example, a 31-year-old woman came to me after years of worsening bloating and distension. Her symptoms were much worse in the evenings and after meals. She avoided heavy dinners and bowel movements and bowel movements gave only partial relief. She had tried everything: SIBO treatment, gluten avoidance, low FODMAP diet, certain antibiotics, but nothing worked. And this is the patient where we need to think beyond food or gas. Most people, and honestly most doctors too, think that bloating is caused by excess gas, having too much gas. But research tells a different story. A group from Barcelona of gastroenterologists developed this technique where they could quantify gas content in patients' intestines. And they compared patients with bloating and with distension to healthy controls, and they found that there's actually a very slight difference in the gas content, just about half a cup more if you were very distended. It doesn't explain that severe distension. That made them look into it and try to find what's causing that difference. It has to be something that the body responds to in a different way. And we know that if we measure abdominal girth or abdominal circumference throughout the day, even in a healthy woman, there's a change in our girth. One study that used a special belt to measure abdominal circumference throughout the day in a healthy woman found that the circumference increased after meals and gradually over the day, but then overnight it decreased and kind of reset into its normal, into the normal circumference. And I think that if you think about putting on a belt in the morning versus taking it off at night, you remember that the same belt feels tighter in the evening. And that daily change is normal, and it's controlled by a reflex. Normally, when we eat or drink, the viscerosomatic reflex kicks in. This is the diaphragm that you can see here, and here is the abdominal wall. They're kind of the wall of the abdominal cavity or the abdominal box, and behind we have the spine. At the bottom we have the pelvic bones, and they make up the other walls of that box. And when we increase the abdominal volume, when we eat, when we drink, we need to accommodate for that extra volume. So what happens is that the diaphragm relaxes to accommodate the extra volume that we eat, and the abdominal wall contracts a little bit to hold everything in. That's a normal viscerosomatic reflex that we all have. But in some people, this reflex works in reverse. So many patients with bloating actually have a paradoxic reaction, or something we call abdominophrenic dysenergia, when the diaphragm and the abdominal wall are not in sync. The diaphragm contracts and pushes down on the abdominal organs, and the abdominal wall actually relaxes. So when the diaphragm pushes down, the internal organs only have one way to go, because we're covered in bony walls, the spine and the pelvis. So there's only forward. And how do we know that that's what happens? So here's what the CT scans show. On the left, this is a baseline state of a patient without too much distension. We can see the diaphragm here and the abdominal wall there. And this is a CT scan of the same person that was done during a flare-up of the distension. And we can see that there's hardly any change in the amount of gas in their gut. It's mostly the distribution because of that viscerosomatic reflex or the abdominophrenic dysenergia. So how do we diagnose that at clinic? And that's a bit of a challenge. So we look for the typical symptoms. Patients with abdominophrenic dysenergia have a typical pattern. They have distension that's worse in the evening. It becomes better overnight and kind of resets in the morning. It's usually a little bit worse with meals, and sometimes gets partially better with bowel movements. But that is what we're looking for in our patients. And if constipation treatment doesn't help, then we're pretty much left with abdominophrenic dysenergia after we ruled out other structural diseases. And what do we do about it? So the key is to explain the underlying mechanism to patients. It helps them understand why we choose our therapies. And our goal is to sort of retrain the diaphragm and restore the normal viscerosomatic reflex. And we usually start with diaphragmatic breathing, mostly because that's what's most available. That group in Barcelona that discovered the abdominophrenic dysenergia uses biofeedback techniques that actually help patients with their distension. The caveat is that you have to go to Barcelona and probably speak Spanish because it's not widely available yet. We are working on getting it over here, but I'll show you what it means in a minute. Sometimes we also use neuromodulators, medications that calm the hypersensitive gut nerves and reduce the exaggerated stretch that sometimes induces the viscerosomatic reflex in order to help with the diaphragmatic breathing. This is a video from a biofeedback session that was developed by the Barcelona group that led by Dr. Aspiros. And patients are trained to focus on pulling their abdomen in while breathing into their chest. And studies show that this biofeedback improves bloating significantly, both the bloating sensation and the distension. And in that study, they examined their patients and followed their patients for 6 months, and they found that there was a lasting improvement in their bloating and distension. So to sum it up, bloating and distension are very common, and they're not always caused by excess gas. Our understanding of these symptoms is improving, and therapies like biofeedback are becoming more available, but accessibility and efficacy are still limitations. Thank you for staying with us, and hope you feel better.
Hi, my name is Jennifer Kai, and I'm a gastroenterologist at Brigham and Women's Hospital. I want to thank IFFGD and the organizers for this invitation to speak. And today I will be presenting on the topic of belching. So let's jump right in. What exactly is belching? It's commonly known as a burp. And this occurs when gas suddenly escapes from the esophagus or the stomach to the top of the throat, causing an audible sound. And it can be normal to belch. But when does it cross the line to become excessive belching? As I mentioned, belching can occur in healthy individuals, but it becomes a disorder when it's bothersome enough to impact usual activities for greater than 3 days per week in the preceding 3 months, and with the onset of symptoms at least 6 months before the diagnosis. Belching can also occur with many other conditions, including reflux or heartburn, in which case it can occur in up to 50% of cases. Gastroparesis, which is delayed emptying of the stomach, pregnancy, psychological disorders, as well as in patients with hernias or a history of a stomach wrap surgery. Worldwide prevalence of belching is about 1%. Now, there are several types of belching. The first type is called gastric belching. This is the most common form. We swallow a tiny bit of air each time we eat or drink something, and belching allows all of this accumulated air to be released from the stomach. As we see on the diagram, air moves from the stomach through the esophagus, which is our food pipe, and out the mouth. This process can normally occur up to 30 times a day. Often when we talk about belching, the term air swallowing also comes up. So what is air swallowing, and how does this relate to belching? Excessive air swallowing is also known as aerophagia, and this is the process where air enters the esophagus by contraction of those esophageal muscles, called peristalsis. Then the lower esophageal sphincter, which is the muscle that connects the esophagus and the stomach, will relax, and air will flow into the stomach. You see here that the directionality of the arrow is the exact opposite of what happens in gastric belching. So it's no surprise that air swallowing can actually worsen gastric belching. Air swallowing is also associated with bloating and distension as air travels further down to the intestines. This is a common condition and can be present in up to 30% of patients. Now, there are certain dietary habits that can make air swallowing and belching worse. These include drinking carbonated beverages, eating hard candies, chewing gum, and for those who are lactose intolerant, ingesting dairy. And finally, certain carbohydrates, such as broccoli or cauliflower, can also increase gas production, leading to belching. Now, let's move on to a real-life patient case that offers a practical example of disordered belching. In this case, a 25-year-old woman who has a history of reflux and anxiety has been suffering from frequent belching that can occur up to 70 to 80 times a day. This has impacted her ability to finish a meal, participate in events, and even work. Her belching has worsened over the past 8 months after an infection that caused several days of nausea, vomiting, and abdominal pain. This is an example of the second type of belching, known as supragastric belching. This can occur in 3.4% of patients with upper GI symptoms. In this case, air is suctioned into the esophagus due to either the diaphragm, one of our breathing muscles, or by an increase in throat pressure. As that suctioned air goes into the esophagus, it is then immediately expelled without ever reaching the stomach. So, unlike gastric belching, this excessive air swallowing is not thought to be related to supragastric belching. Supragastric belching is also initially thought to develop as a voluntary response to abdominal or chest discomfort, or in some cases, increased stress. As the belching continues, it can then become an automatic response where the patient has no control over when it occurs. Supragastric belching can be associated with psychological factors such as anxiety or depression. And interestingly, the absence of belching is noted during sleep, when speaking, or when patients are distracted, and also can be worse after and during stressful events. So, how do we differentiate between these two types of belches? Your doctor may recommend two different tests which use catheters or thin, flexible tubes inserted into the nose to measure pressure and acid levels in the esophagus. These tests are called esophageal manometry, the figures in blue and green, and a pH study, the figures in pink. These tests can show whether the air actually reaches the stomach or stays in the esophagus. You may also ask, why is it important to differentiate which type of belching you have? Because this treatment strategy will often depend on that. If you have supragastric belching, behavioral treatment is a mainstay, and they may include diaphragmatic breathing, which uses your diaphragm muscle instead of your chest muscles to breathe. Practically, you will see your belly push out when you inhale and fall back in when you exhale. Cognitive behavioral therapy is a type of psychological treatment that helps you notice and change unhelpful thoughts and behaviors. Relaxation training, gut-directed hypnosis, and speech therapy can also be effective tools. If your belching is thought to be primarily related to reflux, then an acid-blocking medicine such as a proton pump inhibitor may be helpful. And then finally, neuromodulator medications such as baclofen may help the lower esophageal sphincter not open and close as frequently to prevent belching. Importantly, there are also dietary and lifestyle changes that can be made to help belching, including avoiding those foods and drinks that can cause gas, trying to eat more slowly and chew food thoroughly. For those of you who have dentures, ensuring that there's a proper fit, and also smoking cessation, all of which can increase the rate of air swallowing and belching. And finally, taking a short walk after eating may also help with digestion. I also want to briefly mention a disorder that is related to belching called abelchia. Abelchia actually means the inability to belch. So this is a related but opposite problem where the muscle that connects the throat and the esophagus doesn't relax properly to allow gas to escape. Symptoms may include chest pain, gurgling, bloating, and distension. If you have abelchia, you can ask your gastroenterologist or your ear, nose, and throat doctor about whether a Botox injection to that muscle, noted by the arrow there, can be helpful. Finally, I'd like to end with a few words about how to discuss belching with your gastroenterologist. Belching can sometimes be an uncomfortable and perhaps even embarrassing symptom to discuss, but being open and describing your symptoms can help your doctor figure out what's really happening. You might consider starting a 2-week diary to track your symptoms as well as your eating habits. Some things to potentially include in that diary include frequency. How often are the belches? Do they come and go, or are they constant? Timing. Does it occur after eating or drinking certain foods, or when you're feeling anxious? And then, are there associated symptoms? Any heartburn or regurgitation, difficulty swallowing or abdominal pain, nausea or vomiting, bloating or weight loss? Some of these symptoms may be alarm symptoms, and you should tell your doctor. And then finally, let your doctor know if you have any other GI conditions or disorders, as this may impact their assessment and treatment of your belching. Thank you so much for listening.
Hi, my name is Kenzie Preventure, and I'm a registered dietitian, and I work at Deer Nutrition here in Boston. I'm here to talk about the low FODMAP diet. So, what is the low FODMAP diet? It's the most evidence-based dietary treatment for patients with IBS, and studies show that the low FODMAP diet can improve bloating for up to 50 to 75% of IBS patients. So what does that mean? FODMAP is actually just an acronym for a specific kind of carbohydrates and sugars that bother people who are sensitive to them. This diet was created by Monash University in Australia, and they stand for fermentable, which means that the bacteria can convert small carbohydrates into other substances, and those small carbohydrates are these following FODMAP categories. So the first being oligosaccharides, which includes fructans and galacto-oligosaccharides, and they are found in wheat, onions, garlic, and beans. Then disaccharides, which is lactose, and that's found in lactose-containing milk, yogurt, and sour cream. And then monosaccharides, meaning excess fructose, which is found in honey, mangoes, and high fructose corn syrup. And then lastly, we have the polyols, which are sugar alcohols like mannitol, sorbitol, and xylitol. And a lot of these are man-made and found in products like sugar-free gum, but there are also some naturally occurring like in mushrooms and sweet potatoes. So these short-chain carbohydrates are poorly absorbed in the small intestine. So they move to the large intestine pretty much completely intact, and it's in the large intestine that people who are sensitive to FODMAPs could possibly feel a reaction. Once these small fermentable carbohydrates land in the colon and the large intestine, some attract water into the colon, some are fermented or eaten by the bacteria in your colon, and these two actions can cause bloating and pain for people who are sensitive to FODMAPs. So since these small fermentable carbohydrates can have such a negative effect on people who are sensitive, it makes sense to try to limit their consumption, leading to the low FODMAP diet. But it's not a diet that was created to be a long-term solution for IBS, and there are many reasons that we don't want people on this diet for a really long period of time. The diet has been shown to be most successful when people work with GI-informed dietitians to properly guide them through the stages of the diet so you don't get stuck on one stage. So the traditional implementation of the low FODMAP diet has 3 phases. And in the last few years, we've seen more and more adjustments to this traditional implementation to make it easier to follow, less restrictive, but still effective. But I'm going to review the traditional implementation today. So phase 1 is elimination, when you remove all of the high FODMAP foods from your diet. Now, recommendations vary for how long you're supposed to follow the elimination phase. In doing research for this presentation, the longest recommendation I found was 8 weeks, and we normally recommend 2 to 6 in our practice. So after those 2 weeks where you eliminate all of the high FODMAP foods, you're going to come back to us and we'll see if you feel really, really good after the 2 weeks. We know the diet's working, and then we can go on to the reintroduction phase. If you feel no different after the 2 weeks, then we know we can stop the diet, because we know that food is not a trigger for your IBS symptoms, and we want to look for other therapies. And then if you feel okay after the 2 weeks, maybe you feel a little bit better, but maybe you went on vacation and you weren't able to fully do the diet and you want to give it another shot, you can do it for up to 6 weeks. One of the reasons we don't want people doing the elimination phase for too long is because for the whole reintroduction phase, you also need to maintain a low FODMAP diet in order to remove any confounding variables. And the reintroduction phase can take 8 to 10 weeks. So don't worry, you'll still be mostly in the elimination phase for a while. All right, so when we move on to reintroduction, we do want to start reintroducing foods as quickly as possible, because we know that staying in the elimination phase for a really long time can increase food fears and contribute to maladaptive eating behaviors. So Monash doesn't have specific guidelines on how to reintroduce foods. So we've created a protocol where you pick one family at a time to test. So either the fructans or the galacto-oligosaccharides or fructose. And the rest of your diet, you're going to keep low FODMAP. On day 1, you'll test a usual size portion of whatever food you're testing in that family at breakfast or lunch. And then you'll see if you have bloating or gas or pain by bedtime. Then on day 2, if no bloating, all clear, on day 2, you'll test a second portion of that same food at either breakfast or lunch and see if you have bloating by bedtime again. If you do but well on both tests, like no bloating, no gas, that means that you probably can tolerate most of the foods in that FODMAP category, that family. If you do well on day 1 but feel gassy and bloated on day 2, you can probably only tolerate a moderate amount of that FODMAP family. And then if you feel miserable and bloated even after day 1, you have isolated a potential FODMAP intolerance, and you should go back to low FODMAP for a few days to feel better, and then you can start reintroducing foods with a different family. We do recommend to test garlic, onions, and wheat separately, even though they are all technically in that oligosaccharide category. Unsuccessful food challenges do not need to be avoided for life. You kind of just add them to the bottom of the list, and then you try them again in 3 to 6 months. The key with FODMAPs is amounts. So you can likely tolerate very small amounts of every single food on the FODMAP list. It's really just what amount is going to cause a reaction, and that's what the reintroduction phase is there to kind of figure out. It's also important during the reintroduction phase to keep a log of what you eat, when you eat it, and any symptoms that develop, so you can go back over that with your dietitian. Monash, on their Monash app, has a great food symptom log tracker. And lastly, we move on to personalization. So once you know what your food triggers are, you can slowly add back in all the foods that were not a trigger. The goal is to return to a relatively normal, flexible eating pattern. And oftentimes, people can tolerate up to 80% of the foods that they eliminated on the elimination phase. During this time, we can also play around with other targeted dietary therapies like digestive enzymes and other fun things. So here's an example of the high and low FODMAP food list. This is a graphic taken from a study that came out in 2024. And I specify the year because Monash University is constantly doing research on FODMAPs and updating their database for consumers via their app. So their app will always be the most up-to-date information for information on high and low FODMAP foods. Any list you find online will quickly become outdated. I will also mention that the Monash app is about $8, but it's a one-time fee. Some of the reasons we don't want people to follow along a low FODMAP diet for longer than necessary: social and lifestyle changes. Obviously, going out to eat, going to events, and traveling can become pretty challenging if you can't eat garlic and onions. Then we also worry about getting enough nutrition. The low FODMAP diet takes out a lot of fruits and vegetables, so we worry about lack of fiber potentially causing constipation. And then we also worry about your micronutrients. So especially if you remove all dairy foods, we're worried about calcium and vitamin D. And then with less fruits and veg, we're worried about all the B vitamins and just making sure you're continuing that well-rounded diet. It can be difficult to learn. The low FODMAP diet is most successful when patients work with a registered dietitian. It can be costly, and then it can also cause changes to your gut microbiome. So those bacteria in our guts that use the fermentable carbohydrates as fuel to create different compounds to flow to our brain and bodies and have health-promoting effects in those areas. So we want you to continue to eat FODMAPs because we want those compounds that they create. And lastly, with any restrictive diet, there's always a risk for disordered eating and food fears. So who should try the low FODMAP diet? First, I recommend finding a GI-informed dietitian before attempting this on your own, but we've seen really great effects for people with IBS-D. We see good effects for people with IBS-C when they're already on a successful bowel regimen, because like I said, we're worried about taking out too much fiber and causing more constipation. So we want to make sure you're having normal bowel movements first. Then a lot of doctors also recommend this diet for symptom management for a condition called SIBO, but it should be noted that it's not a treatment for SIBO, but it can help with symptoms. And patients who have access to a GI registered dietitian, and IFFGD has a list of GI dietitians by state on their website. So people who may not benefit from the low FODMAP diet would be people with eating disorders unless they're working closely with their dietitian, children, elderly without support, and people who do not have access to low FODMAP foods, have trouble with food prep, or have difficulty reading labels. And then we have some resources for patients. So I mentioned the Monash app, one of my faves. You can also track on Nourishly or Monash again. And then a lot of my patients really like the Spoonful app, which allows you to scan barcodes of different foods like in the grocery store and see if they have FODMAPs. And here are my references, and I thank you all for your time.
Hi, my name is Judy Nir. I'm a physician at Beth Israel Deaconess Medical Center here in Boston, Massachusetts. I'm the director of the Center for Irritable Bowel Syndrome and GI Motility here in Boston. One of the first things that we talk about in clinic when patients have chronic symptoms of abdominal pain, diarrhea, constipation, is that you can have a disorder of brain-gut interaction. And these are diagnosed as functional bowel disorders. These are incredibly common. 1 in every 4 adults in the US, Canada, and the UK has actually had one of these 6 very common functional bowel disorders. You can see here on the pie chart that you can have very commonly irritable bowel syndrome. That's the most common thing that I see. Abdominal pain with a change to the bowel movements, but without any alarm symptoms. So no blood in the stool, abdominal, nighttime symptoms like diarrhea at night, weight loss, or family history of Crohn's disease or ulcerative colitis, or what is known as inflammatory bowel disease. But why is this important in women? Women are twice as likely to have irritable bowel syndrome. There are a lot of reasons why this may happen. One of the things is that a lot of the chronic pain issues that coincide with irritable bowel syndrome are much more common in women. We don't know why, but fibromyalgia, chronic fatigue, chronic pelvic pain, chronic pelvic dysfunction, and migraines are just more common in women compared to men. The other thing that I'll talk about in a minute is actually about hormones and the fluctuation of hormones in women and females with those hormones that change with menstruation, but also with changes in life. So at the time of menopause and afterwards. The other common thing that I'm going to talk about is actually endometriosis that actually coincides often with irritable bowel syndrome. It's actually not talked about a lot, but infections are very common in the GI tract. It is thought to occur in over 10,000 people per year. So 1 in 6 individuals in the US will actually have a risk for an infectious event in their GI tract. And afterwards, women are 2 times more likely to have irritable bowel syndrome after that infection. So those chronic GI symptoms that seem to linger for a while afterwards, compared to men who are less likely to have that occurrence. I'm going to talk about this idea of menstruation and how it changes your GI symptoms. So a lot of women say, well, it's really common for me prior to my period to actually have abdominal discomfort, bloating, and then during the period, and then afterwards potentially get better. And this is actually natural. The variation that you can see here in the hormones, and this is a very complicated chart to basically say we have fluctuations of estrogen, of our progesterone, and that can alter our GI symptoms. We've actually done studies where they actually follow people who have been diagnosed with irritable bowel syndrome and those healthy women who don't have any GI symptoms. And when they actually report the same symptoms. The severity is just different. So actually, you get more abdominal pain, more bloating, specifically before the period. People tend to get more constipated, but obviously there are caveats to that. Some people do not. And then during the period, you seem to have more diarrhea, a little bit lessening of that abdominal pain, lessening of the bloating, because of the changes to menstruation. It can be heightened again because you have irritable bowel syndrome. So it's something to consider. What is normal is that, yes, there are some variations, but if it severely impacts your life, then it's something to talk to the gastroenterologist about to your primary care doctor about how that's affecting you, the GI symptoms surrounding the period. What do we know about menopause and GI symptoms? So along with hot flashes, night sweats, sleep problems, mood changes, vaginal dryness, there's actually changes to our GI tract. And there's not a lot known about this area. Some studies say to us that actually your GI symptoms could get worse as menopause occurs, more constipation, more diarrhea, potentially more abdominal pain. But there are other studies that show it actually improves with time. So it's unclear exactly how menopause would affect the GI symptoms, but it's just important to note that some of these symptoms may be due to those changes to the hormones. And again, if you have these symptoms and the change of life is happening where you are missing some periods, feeling some GI symptoms, some of that may change over time as the final last period occurs for someone like yourself. The next thing I'm going to talk about is actually endometriosis, which is thought to be prevalent in about 10% of the female population. What does it mean? It means that you have endometrial tissue that usually is in the uterus, but found elsewhere. So it could be found in the GI tract, it could be found in the abdominal cavity, it could be found in the bladder. So there can be any location where this endometrial implant has occurred. Why is this important in the GI world? It's because many of these people who have endometriosis actually have symptoms of irritable bowel syndrome. So those same symptoms of abdominal pain, change to the bowels, difficulty with defecation, pain with defecation, all of those are actually very common symptoms of IBS. But then the same people who have endometriosis actually are being diagnosed with IBS. Again, why is this different and why would it make a difference for you? It's that if you're having symptoms, it would be important to talk to your GI doctor about not just the GI symptoms. What are their GI symptoms? So there can be pain with intercourse, so painful periods, irregular periods, heavy periods. In terms of the urinary tract, you can have actually pain with urination as well. So all of this the GI tract interacts with the bladder as well as the uterus, and then also with that hormonal fluctuation. And so it's something to consider. It's something also that GIs are very reluctant to talk about, but it's something that significantly affects treatment. If you are diagnosed with endometriosis, which is typically with the help of our gynecologists to talk about the symptoms and then also the treatment, it can significantly help the IBS symptoms that have nothing to do with GI medication, right? It can actually be hormonal treatment, whether that's with injections or with oral contraception, or sometimes in more severe cases, sometimes surgery. The last thing that I wanted to talk about is actually the pelvic floor. The pelvic floor is incredibly important in women. It can be altered with all the changes of life that I've talked about, including fluctuations in your hormones, including giving birth, including surgeries like hysterectomy or oophorectomy that patients can have. But the pelvic floor is this trampoline that holds the bladder, it holds the uterus, and then it holds the rectum. And all of that has to interact together to actually have a successful bowel movement. And what I mean by that is that you may have symptoms of incontinence, fecal incontinence, for example. So a stool comes out without control. If you have the urge, but you can't actually hold the bowels in, those are all reasons to talk to your doctor. Hey, this isn't just normal aging. This is actually the interaction of all of those organs in and the pelvic floor. So what I was going to describe today is actually how the normal occurrence of having a bowel movement occurs. Usually you sit on the toilet, you get the urge to have a bowel movement, you sit on the toilet, and you actually bear down with your belly. And what happens is the anal sphincter should actually relax. And I always give the example of getting toothpaste out of a tube. If you want to get the toothpaste out, this is the tube, you want to press the tube and then you uncap the tube, right? If you left that cap on and you press, nothing's going to come out. And this is what can happen. It's called pelvic floor dysfunction or dyssynergia. It's very common in women, more common in women, but it is still unclear exactly why it happens more in women. But what's happening is that anal sphincter can potentially not relax or even tighten up, and you may not have great push bear down, pushing down the rectum, so that there's just no forward flow, meaning flow out of the anus into the toilet bowl. What do we do about this? And why does it matter? It's that if you have constipation, fecal incontinence, we have testing for this. The main test is anal rectal manometry, which is a catheter that gets inserted into the rectum, and you do a series of maneuvers. And then if we diagnose that you have dyssynergia or pelvic floor dysfunction, you can actually get biofeedback. This is physical therapy for that pelvic floor. So what that means is that somebody working as a physical therapist would be working with the patient and working with you to actually go through a series of sessions where either their finger or a probe is in the anal sphincter, and you could actually figure out the dynamics of that bowel movement. So relaxing that anal sphincter appropriately and giving that bear down. People often ask me, how often do I have to go? What is this, right? And it is an incredibly invasive physical therapy, but it is incredibly effective. So in studies, 70% of people actually improve their bowel movements, whether that means a decrease in fecal incontinence, improvement in their ability to have a bowel movement, their ability to decrease their laxatives, or potentially to get off the laxatives. For a woman, for females that have that pelvic floor, those muscles need to be strengthened and coordinated, just like your biceps or your thigh, right? That you have to exercise that pelvic floor and in a way that is counseled by someone, as opposed to just thinking yourself or exercising yourself in some random way to actually have appropriate bowel movements or less fecal incontinence. A lot of people do ask me then, is there a surgical alternative for this? Or what are other things you can do for dyssynergic defecation or this dynamic that's a little bit off? Surgery is not a great option. But there are pelvic floor abnormalities like rectoceles, intussusception, all kinds of abnormalities that can be seen in the pelvic floor that are potentially not affecting the symptoms. So what that means is that sometimes we can do imaging. For example, there are MRIs or images that we can take of the pelvic floor that can give us so much detail about what's going on. But in the end, those are potentially the findings, true, and unrelated. That you can find, you have a rectocele, which is just an outpouching that occurs in the rectum. And that's actually not worsening the symptoms in any way or contributing to the symptoms. So it is worth talking to a gastroenterologist just about the whole picture and the dynamics of how the person has a bowel movement, as well as potentially imaging to see what physically is there, and then discuss with the gastroenterologist as well as the surgeon potentially what could be done. Thank you so much.
Hello, welcome back. I hope you've enjoyed today's session of the Nancy and Bill Norton Patient Educational Series event on gastrointestinal symptoms. I know that we've had some great talks, learned some wonderful things, really dug into some symptoms that I've heard of, thought of, but didn't know a lot about. And I hope that you did as well at home. And I'm here to sort of wrap up the day with Dr. Stoller and Dr. Kuo. One of the things I want to circle back to is that early satiation. And so we learned that there was a difference between early satiety, which I hear a lot, and early satiation, which I don't hear quite as much of. So I'd love for you guys to just reiterate to us again what the differences are. And then maybe some insight as to why we talked about satiation in this program and not satiety.
Great question. So I think the challenge is that people tend to incorrectly use these terms interchangeably. And they may say satiety, but really what they mean is early satiation. So early satiation is the feeling you get as you're eating the meal and you feel full before you've reached the typical amount to make you feel full. In comparison, early satiety is the sensation of feeling full in between your meals and not while you're consuming your meal. So most of the time when we talk about GI symptoms, most people are saying, well, I'm having problems when I eat. And if I'm having problems when I eat, whether it be nausea, vomiting, abdominal pain, or early satiation, this is what most people refer to, and this is what comes to the attention of healthcare providers. Early satiety gives you more of the sensation that I don't feel really hungry or full in between my meals. And so as a result, I'm going to eat far less. My overall caloric intake is decreased. I might be leading towards anorexia with general overall malnutrition. Early satiation, though, specifically refers to that time period of when I start that meal. How do I feel as I'm eating that meal? And am I feeling full early during that meal, or is something else contributing to this process?
Okay. So I have a question. So for me, sometimes when I eat, I feel like I still have like a brick in my stomach, like an hour later, like I just finished eating. So that would be satiety, early satiety. Not the fact that I finished eating early, which is probably the case, which was the early satiation, which means people can have both.
Yes, absolutely.
And is that common?
It's extremely common.
Okay.
Extremely common. But I think most people think about early satiation, even though they may use the term satiety, when they are presenting with the symptoms related to meals, which is the most common type of things people talked about.
I think it's important, not that necessarily our patients or our audience here is saying, do I have early satiation or do I have early satiety? Let me get it right to tell the doctor. I think the point is to sort of say, you want to be very clear about when do the symptoms hit you, right? Right. Really say it in plain terms, right? It happens while I'm eating, while I'm sitting at the table. I'm getting full quickly. Or am I eating a normal amount and then afterwards I'm feeling full for a prolonged period of time? I'm feeling uncomfortable and things like that. So I think the important thing is to really provide your provider, your doctor, your nurse practitioner, whoever you're seeing with a really good description of when the symptoms hit you because that tells us about different aspects of how the stomach is working, different aspects of the physiology of the way the stomach works, and in the end of the day, different treatment options as well. So as I said, the terminology is important when we think about it, when we talk amongst ourselves, and not as important to really say satiation versus satiety, but to just describe to your provider what's happening so they can help make the right diagnosis and treatment decision.
Absolutely. Tell it like it is, not try to put a label on it. That's the healthcare professional's job, to sort of make that determination.
Fantastic. And so at what point with either one of these should someone be alarmed? Like anyone could potentially sit down, eat a meal and think, you know what, guys, I'm not as hungry as I thought I was. At what point does that become something where maybe I should go see someone about this?
I think you're absolutely right that there's daily variation or even weekly variation depending on what we eat, what mood we're in, how we're feeling that day, all sorts of environmental factors which can affect this. But when it becomes a consistent chronic pattern for more than 3 months, when it results in significantly decreased overall nutritional intake, resulting in weight loss or nutritional deficiencies, that is when you really need to seek further help from a medical professional, really interrogate what's going on. But admittedly, we all experience these symptoms as part of our daily lives, but the key is the chronicity, and if it has downstream effects such as nutritional status and weight loss.
And I think we will talk about alarm symptoms, and those are important, right? When those come up, do not pass go. It's time to talk to your provider. But I think when you've had these symptoms for a while, and even if they're not causing alarm symptoms like weight loss, like changes in your bowel habits, like blood in your stool, etc., if they're affecting your quality of life, right? That's the threshold that it may not be something that you have to be, quote, alarmed about. But then I think it is worth talking to your provider because they might be able to give you solutions that might help you feel better. So I always sort of say, as Dr. Quo said, right, we can all get these symptoms, right? And we've all had these symptoms where we feel full, we feel like a brick in our stomach after eating. But when it's consistently affecting our quality of life, it's helping us or it's impeding us from being able to go out to dinner with our friends, right? Because we're saying, I don't want to feel that afterwards. That's not normal. And it may not be alarming, but it's not normal. It's worth seeking care so that you can feel better.
Absolutely. And for those of you out there, we talked about this yesterday as well. It doesn't matter if you feel that it is alarming. It is your quality of life that is most important and what is concerning to you. And if you are concerned about something, then talk to someone. If it is stopping you from enjoying who you are and the things that you have done before, talk to someone. And really and truly, that's the bottom line for most of the symptoms. So I do want to bring up something that is very prominent right now, and that's the GLP-1s. So the GLP-1s are known to cause early satiation, and that's sort of one of their goals. So is there any time that you be concerned about taking a GLP-1? Is there any patients that maybe this isn't a good idea for them, that early satiation is not something that they want to induce? Or is there a point in taking it that you should be alarmed and maybe stop taking it because you feel that there may be a problem with this early satiation?
I think these GLP-1s are a fascinating topic. I think GLP-1s have been around in one form for a little while in terms of the management of diabetes, but then a newer form, essentially higher doses, have been utilized to promote more impacts on the GI tract system and the endocrine system to encourage further weight loss beyond diabetic control. So these doses are higher, and as a result, with being higher, they have more impacts upon the gut, which means early satiation, early satiety, nausea, vomiting, because they exert all sorts of influences on slowing down gut motility, as well as rearranging how the body perceives various signals that it sends off when the GI tract is filled with food. And I think this is a very tough area of balance where it requires discussion with the patient, as well as the primary healthcare provider, and even the GI doctors, if they're involved, to figure out what is the balance between taking these medications and impacts on GI symptoms. So, for example, I think improving diabetes is paramount, because if you improve diabetes, that can lessen the impact on potentially long-standing changes to the nerve endings and sensation and overall health care. Improving weight loss is paramount because that in itself can promote diabetes, cardiac issues, stress weight problems can induce back pain, and overall longevity and mortality and morbidity can be improved by losing weight. I think the tricky balance is that trying to weigh the benefits of these types of medications with somebody that may present with GI issues. If they have ongoing GI issues, is it worth the potential side effects of the medications to endure the impacts of these side effects for the ultimate gain of either improving their diabetic control or their weight loss? And this is a very careful, tricky discussion to have. I've encountered many situations where patients have had significant GI symptoms. We've spent years improving their GI symptoms, but admittedly, they have obesity, and then they're faced with a critical choice. I have a GLP-1 medication that I think I can lose weight, but is it worth the risk of potentially exacerbating my symptoms for that weight loss and that overall benefit? And I think it's not an absolute no, that it's not worth the GI symptoms. I think that it's a very careful discussion. And many patients are so motivated that they're willing to have an exacerbation of the GI symptoms for the overall benefit of weight loss. And so I don't think it's a contraindication. I think it's a very robust discussion that needs to be had.
Yeah, I think as gastroenterologists, we don't want to deny our patients opportunity to use these medications because they've been labeled with a GI disease of some sort, right? There's very few real, true, you always can never take it, right? I think, as Dr. Poe mentioned, the risks of obesity and the downstream effects of being obese have such a big impact on risk of cancer, quality of life, things like that, that I think we owe it to our patients to give them the opportunity to try it. I think where the gap that I see right now is education. Many patients are being started on these medications, and they're not being fully informed about the potential side effects. And so then where they're showing up to a gastroenterologist and they're saying, I feel nauseated, I'm vomiting, and they haven't really been told that this is a potential side effect. And so I think the real important thing is that educational understanding when there's a gap right now to say, listen, these medications can cause GI side effects. These are the GI side effects: nausea, vomiting, feeling full quickly, feeling full for a long time, constipation, diarrhea, even issues with the pancreas. Those are all potential possibilities. We need to be aware of them. We can try and treat through them because we think that the benefit may outweigh the risks that are there. But we don't want people showing up and being panicked that they have these GI symptoms when they know that they are a known side effect. So to me, it's really about going in with eyes wide open. These are side effects. They fit with the mechanism of action of how the drug works. We can potentially treat through them. There are many patients who will not be able to tolerate it, and that's okay too.
And I think that just because you have GI symptoms and then maybe you've had a beneficial impact with other sorts of treatments and you start GLP-1s is not a guarantee that on GLP-1s you're going to have symptoms. I think it's very unpredictable. I think the risk of having issues on them is a little bit higher, but it's not a foregone conclusion. And I think that the same strategies that were used to improve their symptoms before could be utilized carefully while they're experiencing symptoms on GLP-1s. But again, it's a very careful balance because these symptoms that you get on GLP-1s are the same symptoms that are probably exerting its beneficial effect upon nutritional intake and weight loss. It's a very careful balance.
Absolutely. Well, thank you so much for helping us to expand a little bit into that. And for those of you out there, what these gentlemen have said is so important, and that is side effects happen with medications. That's what I heard. Right. And so it just so happens as you hear about the GLP-1s, they talk about the GI manifestations of side effects. But there are a lot of medications that have side effects. And throughout our talks yesterday and today, I know the rest of the week, we'll be hearing about some of those symptoms, and you'll hear the speakers say it could be a side effect of medication. So be sure when you are prescribed something new, do not be afraid to ask about what the side effects might be so that you're prepared for those, so that you're not going to your gastroenterologist later and saying, oh my gosh, all of a sudden I'm really constipated, when it was the medication, and perhaps you could work with your healthcare provider to mitigate some of those side effects from the very beginning before they become alarming or troublesome to you. So working with your doctor very carefully on side effects, which could be synonym for symptoms that we are talking about during this program. So I want to move on and talk about belching. So we had a great talk on belching today and all the different categorizations, and it was just fantastic. And I think it was very thorough. But one of the items that I was really concerned about is there ever a time that you should be alarmed by your belching? Is there become a point where you're like, I should go see a doctor about this?
Yeah, I mean, I think belching in and of itself is not the typical alarm symptoms that we've talked about, right? This is not something that is generally a sign of something bad or something scary. And I think that's important to emphasize. But you can imagine belching, right, is something that we all do multiple times per day. It's a very normal response that as our stomach stretches with air, it may vent in order to allow that air to come out. And our stomach is very good at doing that. But you can imagine when belching becomes frequent or it becomes intrusive, that it's starting to affect your quality of life or your ability to function in social situations. That's the time where I wouldn't say it's alarming, but that it's something worth getting checked out, because many people, as we heard from the talk, it's not just swallowed air, right? It's not just that you've had carbonated beverage. It can be other behavioral issues that actually have treatments that are not what you expect them to be. So when that belching becomes intrusive, and it's happening a lot when you're maybe talking in front of an audience like this, right? You wouldn't want to be belching in the middle of this. Those are the types of situations where you should really get help.
Fantastic.
I think oftentimes partners are a good barometer. If they say, well, that's a lot more than before, and you really should have that evaluated. This is not just the occasional belch after a good meal or after carbonated beverage, or the old sometimes when teenagers belch and then you're worried they belch too much, that it may become a habit. I think a lot of people around you are fully aware of what your patterns are like, and if they mention that it's a little different, that's when it's worthwhile seeking attention.
Fantastic. Thank you so much, and I appreciate that. I want to move into another talk that we had. Dr. Judy Nir gave us a beautiful talk about women's health and GI, and we all know that people have for a long time talked about sort of the patterns in their GI symptoms that roll with their menstrual cycle, or things that may get worse or better during menopause. And she talked a lot about the endometriosis and how that affects us. Very, very informative, but it just made me wonder. We hear a lot about multidisciplinary care, especially in gastrointestinal area of health. You see that a lot where they're working hand in hand with other disciplines. Is there ever a time that a patient would want to seek out the care of both a gynecologist and a gastroenterologist to coordinate, since there is so much of a link between these two?
Yeah, I think in medicine, we're really guilty of being in silos, right? We think about this is affecting the GI tract, and I'm thinking about the GI tract, and I'm not necessarily thinking out of my lane. And I think in many ways, GI health is women's health, because these systems are so clearly integrated, not only in terms of that one disease may be common among patients who have things. So for example, IBS and endometriosis, there's a huge overlap. Do we have the information to say, does IBS lead to endometriosis, or does endometriosis lead to IBS? We don't have that information, but we do know that they go together. And so as we start to learn more about these women's health issues that are very much tied to our GI issues, it's important for us. Our job as providers is to say, hey, do you have any of these symptoms that may go along with endometriosis, right? Heavy periods, painful periods, pain during sexual intercourse. These are all things that are very relevant among endometriosis patients and may actually give you a little clue as to what's going on in the GI tract as well. But also many of these things are anatomically located together, right? The pelvic floor, which has a huge impact on GI symptoms, is actually very much located or co-located with the gynecologic system, right? And so many times when one system has problems, the other system will too. And so I think as providers, right, and that's not our audience here, but we need to think about how could these systems be interrelated and maybe I might ask my patient, do you have pain during intercourse as a general topic when we're talking about constipation, because often those things will go together. And so I think bringing these things up and even bringing up, could this be endometriosis? Could this be pelvic floor dysfunction? Patients are their best advocates in terms of even priming their doctor to think about something that doctor may not have thought about until that patient said, hey, what do you think about that? There's so much that I've learned from my patient, and I think women's health is an area that's really understudied, and I think patients can be great self-advocates in that realm.
So do you have any tips on how a woman might bring that up to their doctor? Like, would they just come out and say, I have endometriosis? Do you think this could be related? Is that something that, or would they just go through the symptoms of some of their issues with the
A
heavy?
combination of both. I mean, having a confirmed diagnosis of endometriosis is something that you should always bring up. I think other common urogynecological things might be frequent urinary tract infections. And all this is to say that the nerve endings that involve the bladder as well as the bowels from the sacral nervous system are all intertwined as this complex web. And so going by symptoms or known diagnoses that your primary care provider or your gynecologist or your urologist may have, I think are all relevant points to bring up.
I think the other piece that is difficult both for the patient and the doctors and providers who are seeing them is that over the course of a woman's lifetime, GI symptoms can change even in women who don't necessarily have GI symptoms, right? Or GI illness, let's say. So we know that over the course of a normal menstrual cycle, that on average, as women go from the first part of their menstrual cycle into the second part of their cycle, right, they are more likely to have bloating, maybe looser stools and things like that, even with people who do not have GI symptoms. Now, the interesting thing is that when you have a disease like IBS, those symptoms are really going to be magnified over the course of the menstrual cycle. So realizing that menstrual variation in symptoms is normal, but that it can also exacerbate underlying diseases as well. And then the second thing to talk about is menopause. Really, it's still a black box in so many different ways. There's still so much that we have to study about menopause. But realizing that many GI symptoms that have been around for years and have been relatively constant and unchanging can very much change as women start to go through menopause, and that perimenopausal, then actual menopause time period, that we would expect GI symptoms to change. And it's something that's worth bringing up because maybe we're not all attuned to those like changes when we're thinking only about the GI tract. And so again, patients can be great self-advocates and just saying, I am thinking that I might be starting to go through menopause. Is it possible that that change that's happening in the GYN world is starting to affect my GI symptoms as well?
Absolutely. Always a fan for speaking up for yourself and bringing those things up to your doctor, even if they're difficult. And sometimes, as we've talked about in many of the talks throughout this week, it can be very sensitive to talk about some of these topics, but know that, especially in gastroenterology, they've all heard it. They've heard it before. They talk about it every day. And quite honestly, for those of you out who don't know and haven't spent time with a gastroenterologist, they talk about it all the time. It can be common table conversation, actually, at our business dinners. And so don't be afraid to talk about any symptom, whether it be gynecological or, as you said, the urinary tract infection. That's something that we hadn't talked about or thought about, or any of these symptoms that you have. It's important to tell your doctor, this is bothering me, and just tell them, and let them work with you to see if you can find a resolution to these GI symptoms that are bothering you. So thank you guys so much today. We're going to wrap up our second evening of the Norton Educational Series Gastrointestinal Symptom event here in 2025. We really do appreciate the opportunity to be in Boston. I don't know if you guys can enjoy this beautiful view that we have, and it's been fantastic weather, and it's been fantastic presentations and great conversation. And so look forward to seeing you guys again tomorrow as we move along down the GI system, and we'll talk about lower GI and what symptoms you might experience in your lower GI tract, things that might be a concern, things that might be causing those symptoms. So tune in tomorrow to learn more about that. Dr. Stoller, Dr. Quo, thank you so much for being here with us this week. It's been a pleasure to work with you guys and really, really excited to keep on going and learn more about that lower GI tract.
Thank you very much.
Yeah, thanks so much for having us.
All right, guys, you come back tomorrow and join us for the third day of the 2025 Nancy and Bill Norton Patient Educational Series event on gastrointestinal symptoms. Thank you.